Okay, everyone. So today we're going to talk about analgesic, anti-migraine, muscle relaxants, and anesthetic agents. Uh, this is going to be a little bit of a longer lecture, but that is mainly because it's just basically all the pain killing and similar anti-discomfort medications that we're going to be going over today. So without further ado, let's begin. So what is an analgesic drug? You've probably heard this before, but analgesic drugs are painkillers. And there are several different categories of analgesic drugs that are used to treat varying types of pain. One are salicylates. There's really only one in this category that you have to worry about, and that's aspirin. You have NSAIDs, which you also may have heard about before. Those are non-steroidal anti-inflammatory drugs, otherwise better known as your over-the-counter painkillers, like say ibuprofen, Aleve, naproxen, and there are some prescription strength ones too. We have acetaminophen as well. That's your standard Tylenol. Neurological agents and neurological analgesics, which are used to treat nerve pain. Then we have our opiates and opioids. You'll see those two terms sort of used interchangeably. Opiates and opioids are your very, very strong analgesics, your strongest of painkillers that are often used after surgeries for very serious injuries or trauma. And they all stem from what you can see there, which is the poppy plant. That is the opium poppy. It grows really all over the Central Asia and that area, mountainous regions, especially Afghanistan, Pakistan, India. And that plant is actually where they originally synthesized your opiate medications from. So all of the opiates in some way or another are derived from the naturally occurring chemicals within that plant. So I always like to connect it back to natural products. It's my first love, my favorite topic in pharmacy, as it were. Also, we have combination pain medications as well. Those are your 2-in-1 drugs, which have multiple medications in them, and they provide optimal pain relief in many circumstances. So first of all, we have to define pain. Now, pain is a little bit more than just saying ouch, right? So how does pain actually work? How does it actually start in the body? Well, nerves throughout the body contain receptors that detect stimulation, pain, burns, cold, etc., right? So we have the central nervous system, which consists right there of your brain and your spinal cord. And then everything spinning out from the central nervous system is your peripheral nervous system. So you'll often see these things abbreviated, the CNS and the PNS. So the brain and the spinal cord, that is the central nervous system, the CNS. The peripheral nervous system consists of all the nerves outside of the brain and the spinal cord. And these nerves contain receptors that detect stimulation of any type. So it can range from pain, burns, cold, even just touch. So that's how you know where you are and you have a sense of place in your body, right? Without pain, and there are actually some conditions where people are born without these receptors, it can often be very damaging because they don't have any sort of response if they, say, stub their toe or touch a burning stove or something like that. So that's why pain is very, very necessary and an extremely important sense in the body. That is to say, when it overreacts to certain stimuli, or in the event of trauma, that's when we need to treat pain. So essentially what happens is these nerves from the periphery or from the central nervous system, but usually from the periphery, they carry a signal back to the brain, which causes a pain response. So analgesics work centrally in the brain or peripherally, that is locally, to reduce or block the transmission of pain impulses. We want to block those pain impulses from getting into the brain and causing a pain response. So we have treatments for mild, moderate, and severe pain. You'll often see this as a pain scale. So when we're asking someone to describe their pain, say if it's in a hospital setting especially, or even in just a clinic, they might have someone say, well, on a scale of 0 to 10, rate your pain. And they often have like the happy to very, very sad smiley face emojis as sort of the way to gauge what your pain would feel like. But after we define how severe a patient's pain is, the providers try to achieve analgesia. That is just simply a state in which pain is not felt, even though a painful condition exists. Now we have mild to moderate pain, and that can be treated by a number of ways, some of them over the counter, some of them prescription drugs. But generally for mild to moderate pain, we would recommend acetaminophen, your Tylenol, NSAIDs, salicylates, or combination products or pharmacotherapies. So oftentimes people will combine their NSAID medications, say like an Aleve and ibuprofen, with Tylenol as well. And there is even a combo pill of those two that is now available on the market. Sometimes if you approach pain from multiple angles, you might achieve analgesia a little bit easier. Now for moderate pain, a lot of times we would consider neurological agents that work on nerve pain. That's often considered moderate pain, as well as combination products. So opioids and acetaminophen would be good examples of that. Severe pain, we're talking trauma, we're talking hospitalization, maybe post-accident or severe chronic pain. That would involve the use of combination products. So also opioids and acetaminophen, or just straight up opiates or opioid analgesics. Now we have salicylates, which is a few different types of drugs, but we're going to talk about the analgesic one, which is aspirin, also known as salicylic acid. Now, it's an old and very useful non-addicting analgesic, which we'll talk about addiction and substance use disorder a little bit later. But aspirin is sort of old reliable, and it actually comes from the willow tree, as you can see there, which I think is really cool. Aspirin is derived from willow bark. They've been using it for centuries. It's probably one of the simplest painkillers, the simplest chemicals, but it works really, really well. It's also used in combination with other drugs for cardiovascular diseases, and it comes in multiple dosage forms, both over the counter and prescription strength. So you have your tablets, your chewable aspirin, which is really useful, especially if maybe you have an older patient. And then extended release aspirin, which is useful if you're using it for an extended period of time chronically, and you want to keep that pain relief going throughout. It even comes as a gum, also comes as a suppository. Now, aspirin is used to relieve mild to moderate pain. It's used as an anti-inflammatory. It's also an antipyretic, meaning it's a fever reducer as well. And it's also antiplatelet, or otherwise known as a blood thinner. So that can also be very helpful with patients who have heart disease. Maybe they have a little bit of, say, like arthritis pain or something, or chronic inflammation. They might be able to take a higher dose of aspirin, and you kind of kill two birds with one stone there, right? So you're thinning their blood, you're improving their cardiovascular outcomes, while also helping with pain relief. Now, the thing is with aspirin, generally the pain relief doses are higher than you would expect with the than the like blood thinning doses. So normally you would see like 81 milligrams if a patient is taking aspirin to help with their heart health. They can go up to 325, I believe, milligrams, and that's more of like the pain relieving dose, and that would be per day. Now, side effects with aspirin are mainly gastrointestinal. So those are side effects like reflux. They have to do with your GI tract. So you might experience heartburn, stomach ulcers, and bleeding. So that could be bloody or tarry stools. One sign of bleeding that's very, very common is if a person has a bowel movement and their stools look tarry or black. That could be indicative of internal bleeding and clotting. So at that point, that's usually a time when people maybe want to go see the doctor to potentially change that medication out for something else. And of course, since it's a blood thinner, aspirin is prone to causing bleeding and maybe easier bruising in patients. But again, it's a generally very safe and very well tolerated drug. Now we move on to our NSAIDs, and as you can see, those are non-steroidal anti-inflammatory drugs, and they're used to also relieve mild to moderate pain, and they're more potent or stronger than salicylates at most doses. So they're more potent or stronger than aspirin, but their effectiveness is very patient specific. So one NSAID might work better for relieving pain in one patient than another. I find this actually happens quite a lot in medicine in general. Everyone's body's different. Everyone's metabolism is different. They might have certain genetic factors which cause certain drugs to work with them better than others. And that's an area of pharmacy and genomics that we're still really interested in figuring out and getting more towards individualized drug therapy. But I digress. We're just talking about your standard NSAIDs today. So we have over-the-counter or prescription NSAIDs, and they also work similar to salicylates. They're antipyretics, which you'll recall that means they're fever reducing. and they're also anti-inflammatory. They're anti-inflammatory because they inhibit the inflammatory response of the body, and that reduces pain. So inflammation can press on nerves, press on joints, and that can be a very, very uncomfortable experience. If you've ever sprained your ankle, you know what inflammation feels like, right? So NSAIDs are especially useful at reducing inflammation, and for that reason, they're often used to treat rheumatic conditions in joints or muscles like arthritis, sprains, sport injuries, because they really do a good job of bringing down that inflammation. Now, the other thing to keep in mind with NSAIDs is, again, like salicylates, they have some GI effects, and that's probably the most important side effect to remember from these guys. They can cause ulcers in the GI tract. Those are like open sores in your either like esophagus, your stomach, or your lower intestines, heartburn. Nausea and vomiting is quite common too. A lot of times you'll advise patients to take NSAIDs with food. And they're mostly, these side effects are more prone to happen in older patients. So patients who would be considered geriatric, that is over the age of 65, as well as children. You generally want to avoid using Aleve or ibuprofen, other NSAIDs in kids, because their stomachs and GI tracts are a bit more sensitive. So you can take with food to avoid these problems. For people older than 65, I would recommend Tylenol before a NSAID. And of course, as I said, there's a risk of ulcers and stuff like that. So that in turn carries a bleeding risk. Not as big of a bleeding risk as aspirin, but the bleeding risk is still there. Your examples of NSAIDs, if you guys watch Jeopardy, you see an NSAID just about every night because they are sponsored by Aleve. And that is a naproxen. It comes, I'm sure you're very aware of it. Brand names are Naprosyn or Aleve. And it comes in a tablet, which can be a delayed release or extended release or just your standard one. Also comes as a suspension, which is good for people who may have difficulty swallowing pills. Ibuprofen is also extremely common. You can get it over the counter or prescription strength. That's a tablet, a chewable, a suspension, or even drops. And another one that just recently became over the counter is diclofenac or Voltaren. So this is what we talk about when we're thinking like peripheral nervous system, or sorry, peripheral pain agents, right? So it's a topical gel that works on the periphery. So instead of blocking the pain receptors in the brain from receiving it, it stops receiving those pain signals, that is. It stops those signals from being generated altogether when you put it onto the skin and it absorbs. It's also really good because even though it's an NSAID, with that, since it's topical, it's not going through your GI tract, so you don't have that added risk of bleeding, which is really nice. But diclofenac, Voltaren gel, it's great for arthritis pain, great for, again, joints, rheumatic conditions. The tablet itself is prescription only. Then we have celecoxib, Celebrex, as well as meloxicam or Mobic, and those are two other prescription strength NSAIDs. Next, we have everyone's favorite and probably the most well-known of the pain relievers. You probably have it in your medicine cabinet, and that is acetaminophen or Tylenol, paracetamol if you're from overseas in the UK. It's a non-aspirin, non-NSAID analgesic. Sometimes in pharmacy scripts and stuff like that, you'll see it abbreviated as APAP, that's APAP, just shorthand for acetaminophen. It works in the central nervous system to relieve pain. It's interesting though, because we don't quite know exactly how it works. And it's probably the best antipyretic out there. So a lot of times people will take Tylenol to not just relieve pain, but to bring down a fever as well. It's useful in both pediatric and geriatric patients. So we would recommend Tylenol before any NSAIDs if you want to treat someone over the age of 65 or say under the age of about 12. Now, there are multiple dosage forms for Tylenol. It's a very ubiquitous drug. It's all over the place. You can have tablets that are chewable, especially for kids or people who might have difficulty swallowing. They have extended release tablets. They have even orally dissolving tablets, which literally you just put them on your tongue and they dissolve. Capsules, suspensions, or solutions, also suppositories. They even have infant suppositories that you can use with acetaminophen. Now, you have to dose carefully to avoid liver damage. Liver damage is the main concern with any person who's using Tylenol. you can have no more than 4 grams of Tylenol per day. Now, that's a lot of Tylenol. Normally, you'd be managing your pain. Like if you require 4 grams of Tylenol, you're going to need probably something stronger than Tylenol to adequately manage your pain. But it's still something to consider because it's used by itself or in combination with other analgesics for mild to moderate pain. So you'll see some of these combo products that have acetaminophen. So you have to make sure that these patients who are taking, say, a Furoset, which is to treat migraines, or an Advil dual action, they might think, oh, well, it's just Advil. It doesn't have any Tylenol. It's under the brand Advil. Well, it actually contains acetaminophen and ibuprofen, and it's over the counter. So if someone is taking their Furoset for their migraine, but they also have some chronic joint pain or something, so they're taking that Advil dual action, or maybe they suddenly got a bad sports injury, or they got into a car accident and their back really hurts and they were taking Vicodin, that's hydrocodone, which is an opiate plus acetaminophen. All those combo products with acetaminophen can add up to 4 grams pretty easily if a patient regularly takes Tylenol and then is suddenly prescribed something else that has Tylenol in it. So those are things to keep in mind. Now, opiates and opioids. I don't have to tell you guys about the opioid pandemic. You see it on the news all the time, but opiates and opioids are very, very good drugs. It's just that they have a addictive potential. They're powerful analgesics used to treat moderate to severe pain, and they work directly in the central nervous system to significantly reduce the perception of pain. So they're working right in the brain to stop the perception of any of those pain signals from getting up from the periphery, traveling up the spinal cord through the brainstem, and triggering any sort of response. They should ideally only be used for short periods due to a significant risk of dependence and or substance use disorder. We don't like to say that people are addicted to opiates or opioids, that they have a narcotic addiction. It is a actual disease and disorder, and that's called substance use disorder. And it's also important to use that term because it carries with it opioid addiction and struggles with substance use disorder carry a very, very big stigma in society. So someone is not an addict, they have a disorder. I digress. All opiates carry the same risk of dependence, or I shouldn't say the same. They carry some risk of dependence, but some are more addictive than others. So they range from C1 opiates, that would be like your illegal ones, right? Heroin, street fentanyl, that kind of thing. These really, really, really strong opiates that do not have, I mean, they might have pain relieving, but they can also send you into respiratory depression, overdosing, and death. That ranges from that to C5 opiates, which might be, again, like your combo products, and pretty much every schedule in between. High doses might cause significant respiratory depression. Respiratory depression meaning it slows your breathing down so much that you're not getting adequate oxygen, and that can lead to cardiac arrest and death. And an opiate overdose can be temporarily reversed with this product called naloxone or Narcan. And that comes, you can see it in the bottom corner right there, that comes as a nasal spray or also an injection. But the nasal sprays, I think, are pretty much the best to use because very simple. It's sprayed and absorbed just about immediately through the nasal mucosa, the mucous membrane up there, and it revives the patient from an opiate overdose, gets them to start breathing again, gets their heart going for enough time that you can get them to an emergency room for treatment. Now, opiates are also especially dangerous when used in combination with muscle relaxants, neurological drugs, and benzodiazepines, which are medications for acute anxiety. So that's like your Valium, diazepam, that kind of thing. And they're especially dangerous because they have an additive effect. So they can cause, because all of those other medication classes, the muscle relaxants, the neurological drugs, the benzos, they can also cause respiratory depression. So you get an additive effect that puts someone more at risk for overdose. So a lot of times in the pharmacy, if we see a person who maybe takes benzodiazepines for their anxiety, say they take a Xanax or something for their anxiety every day, which is something you want to keep them on, right? Because it's treating them. You just want to make sure that they're aware that those opiates may have a very strong additive effect. And that's when we recommend Narcan not just to them, but to a family member, so it's on hand. We always love to use the expression that it's like having a fire hydrant in your, not a fire hydrant, what am I saying? A fire extinguisher. It's like having a fire extinguisher in your home, right? You never want to have to use it, but if an emergency happens, you're really, really glad that it's there. Now, adverse or side effects of opiates. This needs an entire slide by itself because there are a ton of adverse and side effects. We talked about the respiratory depression. That can be slow or labored breathing. The other big one that a lot of patients will complain about, it's constipation. So opiates actually work directly in the gastrointestinal tract as well, and it slows everything down to pretty much a crawl. So people who have to take chronic opiates are often chronically constipated as well, and they require laxatives in order to have a normal frequency of bowel movements. Significant dizziness and drowsiness is also very common with opiates. So we always caution patients, especially when they first start it, before they know exactly how an opiate might affect them, to have caution operating vehicles, machinery, or other things that might be potentially dangerous. Nausea and vomiting and stomach upset are also extremely common with opiates. Sometimes they're so common, especially in hospitals, they'll pre-treat people with opiates with anti-nausea or anti-emetic medication. Now, we also have itchiness, skin flushing, or redness, and that's a caution, especially with allergies. People very oftentimes have sensitivities to opiate medications, and that can be anywhere from having very itchiness, that's very common with morphine, to skin flushing, which is a redness, almost like hives over the skin. So we have to be very cautious with opiate allergies. And euphoria, that's where the danger of substance use disorder comes in, because euphoria, or an intense excitement or happiness, otherwise known as the high, that occurs in about 10% of patients. And unfortunately for those patients, that 10% are predisposed to having an opiate addiction. A lot of times, people, 90% of the time, people don't experience this euphoria when taking opiate meds, but it's important to recognize that 1 out of 10 patients might have that experience. So it's especially important to be careful prescribing. Now, there's also the possibility of tolerance, especially with chronic opiate use. So it's different for everyone, but tolerance builds up over time. So dosing might change in patients with chronic pain. So when 5 milligrams of morphine used to do it for a patient, maybe they've been on it for a year or something, and their pain has not gotten any better, you may consider increasing their dosage or switching to another opioid analgesic, which may work better for them. Now, there are signs of an opiate overdose. This is more for your information, but it's very, very, I think, important to know, because it shows signs of respiratory distress and or cardiac arrest. So the signs of an opiate overdose, they range, but oftentimes you'll see blue lips or nails. That's because of a lack of oxygenation to those limbs in the periphery. Dizziness and confusion. They can't be woken up. Choking, gurgling, or snoring sounds are especially common. Slow, weak, or no breathing, and then drowsiness or difficulty staying awake. And that's, if you were to see any or all of these symptoms, that would be a cause for concern, and that's when you would want to administer that Narcan spray or injection. Now, here are some examples of opioid analgesics, and they'll sort of take you through based on the schedule of the drug. So these are your C2 opioids. Those are the ones that you would see locked up in a pharmacy. They'd be in the safe. And these have the highest addiction potential outside of all the illegal ones. So like heroin and stuff like that, because that would be a C1. But anyway, C2 opioids, that's morphine. There's MS-Contin, and that's an extended release tablet, capsule. There's also solutions and injections of morphine. They're very common in hospital settings. Especially you'll see them in an ER and a crash cart if you have some experience in Bay State. The Paradine or Demerol is available as a tablet, a syrup, or an injection. Hydromorphone or Dilaudid, very high addiction potential. Again, it's often not used outside of hospital settings, but it is used occasionally. Some people with very, very bad chronic pain do use it. I've seen it dispensed in community pharmacies as well. That's available in tablets, capsules, or injections. Now, Oxycontin, that's Purdue Pharma. If you, there's multiple documentaries, and I could go off on my soapbox all day about all the problems with Oxycontin. Those are extended release tablets to provide analgesia, really for what is supposed to be short periods of time for very, very severe pain. But unfortunately, as Purdue found out, huge addiction potential and a big driving force in the opioid epidemic. I would say it's a pandemic too. It's all over the world that we know today. Fentanyl, this is what you hear a lot, especially in terms of street drugs. You hear about certain pills being cut with fentanyl, heroin being cut with fentanyl. It's an extremely powerful analgesic. It's often used for patients, especially cancer patients or palliative care patients. So if they're in end of life care or they're in a lot of pain, either from the chemotherapy, the radiation therapy, or just the cancer itself, fentanyl can be really, really, really useful, especially when it's given as a patch for an extended release. You can keep that patch on the skin for about 72 hours and it provides a continuous pain relief. So these poor people who need that fentanyl patch for whatever severe pain they're going through, they can really manage it well if they use the patch, place it on the skin, and then that's good for about 3 days. Now, we also have combination opiate medications as well. Those are tablets and liquids. The most common ones that you'll see are Percocet, which is oxycodone plus acetaminophen, and Vicodin, which is hydrocodone plus acetaminophen. Now, we have some C3 opioids as well, so they have a lower abuse potential than the C2s. Again, some combo ones. You have your codeine and acetaminophen, which is Tylenol with codeine, Tylenol number 3 or Tylenol number 4 as a brand name, used for moderate pain. And of course, as I mentioned earlier, you have to avoid using that with other drugs that contain acetaminophen. Now, they have also liquid and tablet dosage forms as well, which can be useful depending on the swallowing ability of the patient. C4 opioids, again, with a lower abuse potential than C3s. That's where you get tramadol, very, very commonly prescribed. It's for moderate to severe chronic pain, often used when non-opioid painkillers are insufficient. So a lot of times that might be the first opioid that people jump to if, say, Tylenol and Aleve are not cutting it for pain relief. C3 and C4 opioids still have a risk of respiratory depression, opioid overdose, and abuse or dependence. However, that risk is not as great as it is for C2s. So you could still overdose potentially on C3 or C4, even C5s, if you took enough of it. But it is not as dangerous or with as much risk, I should say, if it is properly prescribed and properly adhered to by both the physician and the patient. Next, we have buprenorphine and naloxone, which is used to treat opioid addiction or substance use disorder. Suboxone is very, very common. It's a C3 medication, and it's used as a sublingual film. So it's just placed right under the tongue until they dissolve. You can see that film right there. It's just a little thing. A lot of people will take 1 or 2 of them under the tongue, usually either once a day or twice a day, depending on the amount or tolerance to opioids that patient has. The good thing about this, even though it is an opiate medication, it doesn't get the patient high. So it helps alleviate any opioid withdrawal symptoms, and the dose of Suboxone and those films is gradually decreased until the patient achieves recovery. It's often prescribed, especially in the Western Massachusetts area, at places you might have heard of Right Choice Health Group. They're absolutely an amazing organization. They do a lot of help. When I was working in specialty pharmacy, we would do a lot of work with Right Choice, following up with patients to see their recovery journey. And it really is extraordinary, the type of supports that they have. Side effects with naloxone, buprenorphine and naloxone or Suboxone. Those are patients, they're going to experience opioid withdrawal symptoms at first. Opioid withdrawal symptoms are often described as the worst flu you've ever had in your life. So the way the withdrawal often works is once the body achieves a certain equilibrium, a certain balance, and achieves a tolerance to any medication, in this case, opiates, you're going to have sort of a rebound effect if they suddenly stop taking them. So what do I mean by that? Opiates suppress your respiratory system, right? They make you breathe less frequently. They lower your heart rate. They're depressants, essentially. So what happens? You sort of get this rebound, flu-like symptoms, these, you'll suddenly get fever, chills. You've been in this state of analgesia for so long, everything will start to hurt. So you'll get muscle aches, irritability. Instead of constipation, your body was compensating for the opiates. Now you'll have diarrhea. Very, very nasty stuff. People can, they feel, again, like I said, worst flu in your entire life. So to avoid that horrible withdrawal symptoms, not completely avoid, but to avoid the worst of it, we like to start people on Suboxone and then slowly titrate them down. So they're not quitting cold turkey, because that is a recipe for a few very, very miserable days. Now, let's move on to neurological analgesics. So these are also called adjunct treatments for pain, meaning that these drugs are generally used for neuropathic or nerve-related pain, which occurs when the immune system is damaged or not working correctly due to an underlying condition. So this can be anything from nerve damage after an injury. Maybe you get in a car crash, you get a pinched nerve. Diabetic neuropathy, so that's a damaging of the nerves which occurs in the periphery, like the hands and feet of people with diabetes, that's untreated. Shingles, if you've ever heard of shingles, that's actually the varicella, the chickenpox virus, which recurs into these very, very painful skin flare-ups and hive-like conditions that are extremely painful, especially in, it generally affects older adults, maybe over 50-ish. Fibromyalgia, which is a chronic nerve pain disorder that affects pretty much throughout the body, and sciatica. You've probably heard of sciatica. That's when you have nerve pain sort of shooting up your leg and into your hip. And that would be a pinching of the sciatic nerve. Now, these may be used to in combination with NSAIDs. Again, adjunct therapy, it sort of means like as in combination with something, to treat chronic neuropathic pain. Pain coming from the nerves is neuropathic. So essentially, as you can see, these are just not to get too technical on you guys, and they're not going to ask this on the pharmacy technician exam, but I think it's good just to have a visualization sort of how it works. I'm a visual learner, so I like to pass it on to you guys. So normally pain is transmitted from these two ends of these neurons, right? And it's being transmitted from one neuron to the other, and that signal goes to the brain and triggers a pain response. Gabapentin, see this little like red dot right there, that binds to the receptors to reduce the neurotransmitter release. So you can see gabapentin binding to those little receptors right there on the cell, and it's stopping those pain signals and chemicals, those nociceptors, from receiving any sort of signal that there's a painful stimuli. So that's how we get rid of that nerve pain. We block the signal from being interpreted by the brain. And that's by working directly in the brain to reduce the release of pain signaling neurotransmitters between neurons. Now, examples of neurological agents. We have gabapentin, which is probably the one you'd see most of the time, especially in a community setting. Its brand name is Neurontin. So very easy to remember, right? Because Neurontin sounds like nerve, so it treats nerve pain. Comes in capsules or tablets, and it's also used in epilepsy and seizure disorders as well. So it's sort of a interesting drug. It has a lot of different uses. In terms of its used for pain and nerve pain, multiple side effects. It's a very nasty drug in terms of side effects. The main things to worry about are dizziness and drowsiness. It can really sort of zonk people out. Nausea and vomiting is very common with gabapentin as well, in addition to weight gain and peripheral edema. So that causes water retention in limbs. And so that's why a lot of people don't like taking gabapentin, because it can make them gain weight. It can also cause an unsteadiness and loss of coordination. So again, gabapentin is one of those drugs where you really have to be careful before driving or operating any sort of motor vehicle or heavy machinery until you know exactly how that drug will affect you. It's not currently a controlled substance, but it's treated as a control in many pharmacies, including in the state of Massachusetts, due to risk of dependence and misuse. Similarly, you've probably heard of Lyrica as well. Those come in capsules. Its generic name is pregabalin. Its side effects include nausea, vomiting, dizziness, drowsiness, very much similar side effects to gabapentin. Weight gain, unsteadiness, and loss of coordination. The one difference it has between gabapentin and pregabalin can cause facial swelling or angioedema. So it's not very common, but in some patients, it'll cause their lips to swell up, and it's a very nasty side effect. It can actually cause breathing issues if it gets really bad. And pregabalin is also a C5 drug, a Schedule 5 drug. So it does have a risk of dependence or misuse. It's not as abused in America as it is in some other places. I believe in Ireland and the UK, I think it's one of the most abused drugs. What happens is people will open the capsules and snort them or melt them down into with other medications to get sort of a high from it. Very nasty, very, very unsafe, but thankfully not as huge of a problem in America as it is in other countries, especially in Europe. The big point to remember with these neurological agents, gabapentin and pregabalin, serious respiratory depression risk, especially when used with opiates. So because both of those medications depress the central nervous system, your central nervous system is partially responsible for controlling your breathing, your respiration. So if you have two drugs that are heavily suppressing the central nervous system, you're going to get problems breathing, or you're going to have risk for problems breathing, especially when other factors are precipitating. So like if you're on opiates and gabapentin, do not be on benzodiazepines, that is, those anti-anxiety medications. Try to avoid alcohol as well, any other thing that could potentially suppress respiration. Now, accidental opiate overdose increases when opiates are co-prescribed with gabapentin. So this just shows you how serious it is, right? So there's a 60% increase in the odds of accidental opioid-related death when opioids are co-prescribed with moderate and high-dose gabapentin compared to opioid use alone. 2 times the risk of accidental opioid overdose, nearly doubled with a co-prescription of very high-dose gabapentin with opioids, and 46% of all gabapentin users who were co-prescribed an opioid in 2013. And that's making the risk of overdose particularly concerning, as these drugs are often used together, right? Because you might have chronic pain as well as nerve pain. They're very often prescribed together. So that's why it's very, very important to be recommending naloxone, to be recommending, just to be educating patients basically on this risk. All right, moving on. So these are a little different. These aren't quite considered analgesics, but they fall under a similar category where they're either treating or preventing migraines, which can be very painful conditions. But what is a migraine? For those of you who have experienced migraines, they need no explanation. But for those of you who have not, migraines are persistent or throbbing headaches which occur on one side of the head. So they're different from, say, like a tension headache. Tension headaches usually occur on both sides, maybe in your forehead, or you might have a sinus headache if you have a sinus infection or something. Migraines, usually one side of the head, and they hurt. They're often also accompanied by nausea, disturbed vision, and a sensitivity to light. They're caused by a number of issues, but mainly vasodilation and inflammation of blood vessels. So these blood vessels are opening up in the head, and they're opening up, but also causing inflammation. The inflammation presses on nerves. That causes pain. It may also be caused by the inflammation of nerve endings themselves in the brain, and that can cause inflammatory neurotransmitters in the brain to go off and to cause very significant pain that is debilitating, in fact. Lots of people, if they get a migraine, they got to take off work. They cannot function that day. So treatment options, a lot of times aspirin, acetaminophen, Tylenol, or ibuprofen is used over the counter for the treatment of migraine headaches. Many people are fine with using these. They just have to do that, maybe lie down for a little bit, and they're okay. Caffeine and butalbital also reduce inflammation. They contract the blood vessels in the head, so they work as vasoconstrictors. If migraines are caused by the vessels being open too wide, releasing too much blood, causing this inflammation in the head, then it makes sense, right, to constrict those blood vessels to reduce that inflammation. We also have triptans, which are a class of prescription medications used for severe migraines, which don't respond to your NSAID medications like ibuprofen. So prescription migraine agents, we have a few options. As we mentioned before, we have Furoset, which is butalbital, acetaminophen, and caffeine. Those are all combined into one tablet. Butalbital and caffeine vasoconstrict and reduce the inflammation, and acetaminophen works as the analgesic to deal with the pain relief. There's also Furanol, which the only difference between that and Furoset is it has butalbital as well as aspirin and caffeine instead of acetaminophen. Those come in capsules. They're a C3 drug, so they do have some use, some risk of abuse or misuse and dependence. And those C3 drugs, it's due to the concentration of butalbital versus aspirin. So you might be wondering, well, why is Furoset not a scheduled substance rather than Furanol? It just has to do with the concentration. It's sometimes combined with codeine as well. So you'll see Furanol with codeine. So that's actually 4 pills in one, essentially. And again, that's also a C3 drug. Next, we have triptans. Your triptans are quite common for migraines. Certain forms come in tablets. They're usually orally dissolving tablets as well, the ODT tablets, but they can also be used as nasal sprays or injections. They're used in the treatment of severe migraines, and they reduce neuronal excitability in the brain. So they stop those neurons from getting overexcited in the brain and causing a pain response. Side effects of triptans could include weakness, fatigue, dizziness, a tingling or a heavy feeling, especially in the limbs. But even then, those side effects are much preferred to migraines, and many people swear by using triptans. Now, sumatriptan or Imitrex is definitely the most common one. You see it prescribed there, and you can see it down there. Those are the orally dissolving tablets. They come in those little blister packs in the little boxes. But there are others too. There's elatriptan, which is Relpax, and rizatriptan, which is Maxalt. And looks like we got muscle relaxants next. All right, so muscle relaxants, they are used to treat acute painful muscle spasms and musculoskeletal conditions. So think of your strains, your sprains, or injuries. Used very, very commonly, especially in, say, sports medicine. You can bet any players on the New England Patriots have probably at some point used muscle relaxants after they had a pretty bad tackle. Again, you want to avoid using these with opioids, benzodiazepines, alcohol, and other depressants, which might increase sedation. Muscle relaxants make you tired. They make you drowsy. You also have to avoid using them for more than 3 weeks. After more than 3 weeks, they're not effective, and they also have a risk of dependence. Now, side effects, of course, sedation, very, very caution driving vehicles, heavy machinery until you know how it affects you. There's dizziness, vertigo, and fainting are also quite common. So there's this thing called orthostatic hypotension, which is just a fancy word for saying you get dizzy when you stand up too quickly. This is very common, especially in older patients as well. And we try to avoid muscle relaxants in those older patients because they might be unsteady on their feet to begin with. They stand up too quickly. They're taking a muscle relaxant. They might fall and break a hip. And then we have a whole other pain management thing to deal with, right? So usually we advise these people to take some time standing up. Muscle relaxants can also cause sort of effects that you wouldn't necessarily think would go along with sedation, but they may also cause, depending on the patient, agitation, irritability, tremor, and insomnia as well. Examples of muscle relaxants, your 2 most common ones are probably carisoprodol, otherwise known as Soma. It's a C4 drug, Schedule 4 drug, so it has some potential for abuse or dependence, and it comes in capsules and tablets, as well as cyclobenzaprine or Flexeril. I always remember Flexeril because if you're flexing your muscles, you're trying to relax your muscles, has a direct effect on it. Cyclobenzaprine isn't scheduled though, so it might be preferred, especially if patients are taking maybe other scheduled medications like opiates. And it comes in capsules or tablets. And lastly, we have our anesthetics. We're breezing through this, guys. If you've made it so far, congratulations. Anesthetics are drugs which cause an absence of sensation or pain. Local anesthetics, they block the pain conduction from the peripheral nerves to the central nervous system without a loss of consciousness, which is really, really nice. So you are conscious, you don't have to be knocked out if you're using a peripheral anesthetic. So those are the types that you would expect in a dentist office or what you might find with a lidocaine patch. So local anesthetics are used for multiple things, but dental work or injection, like a Novocaine injection, that's a local anesthetic. Another example would be a spinal or epidural injection, a caudal IV for birth pain. Even like aloe vera and skin creams would also count as local anesthetics, especially for sunburn, hemorrhoids, or skin irritation. Your topical creams and gels, which I'm sure you guys made in your compounding lab. An example of a local anesthetic that's very often prescribed and also available over the counter are your lidocaine patch or lidoderm, often put right on the back, right, like you see down there. It's used topically for muscle pain. It's also available in over the counter and prescription strength. We have general anesthetics as well. This is what you'd see in a hospital. It's used to depress the central nervous system or to a level of unconsciousness. So it's administered by an anesthesiologist or a nurse anesthetist via inhalation or via intravenous infusion. So if you've ever seen or been in an operating room or gone under for a surgery, you've experienced a general anesthetic. They're administered during surgery to give a patient a more comfortable experience, and side effects that have to be very, very carefully monitored by the anesthesiologist and the nurses, any team that's available, are respiratory depression and post-operative nausea. A lot of times they'll treat or administer anti-nausea or antiemetic medication right away after a surgery because the post-operative nausea and vomiting is so common with some of these medications. So examples include inhaled ones. Your most common ones are isoflurane or Flurane and sevoflurane or Ultane. And then we have our IV ones as well. Ketamine or Ketalar, very, very commonly used in ERs as well, for not just to be used as analgesia, but also to sedate patients, maybe if they're agitated. Propofol or Diprivan, this is a milky-like infusion, which is infamous because it unfortunately led to the death of Michael Jackson. Michael Jackson was getting propofol from a very, very irresponsible doctor in order to fall asleep. And he was overdosed on the propofol because it caused respiratory depression and ultimately cardiac arrest. And the poor guy died at about 50 years old. And then also we have intravenous etomidate or amidates, again, very, very commonly used in ERs and for sedation, either for ventilated patients or for other patients who might need a higher level of unconsciousness or sedation. So that is the end of the presentation. I hope you got something out of it, and I will see you later. Let me know if you have any questions. Thank you.